अभी लाइव हुआ नहीं है।
Yes, sir, we are live.
Okay, good afternoon, everybody. Today we'll have a talk on basics of total hip replacement, and Dr. Ratnesh Singh, who's a consultant orthopedic surgeon with us in Paris HMRI Hospital, Patna, is going to be doing the talk, and he's going to basically talk to you about what are the important things when you plan to do basically this will be more about primary total hip replacements than revisions, etc. So over to you, Ratnesh.
Yeah. Good evening, everybody. Today I shall discuss more of the basics. So I shall start with the history. So in 1912, Sir Robert John used gold foil as interpositional layer. So it was called interpositional arthroplasty. And later other materials are also used like muscles, fascia, skin, oil, rubber, cellulose, and pig bladder. In 1923, Smith Peterson introduced the concept of mold arthroplasty. And in 1933, Pyrex glass was chosen as a material for the first mold. In 1937, Winnable and Stuck developed Vitellium alloy, that is cobalt chrome alloy, in some form of with some modification. We are still using that as a head and stem for cemented one. In 1950, Jude and brother used acrylic femoral head prosthesis that was made of methyl methacrylate. In 1952, the Austin Moore and Thompson prosthesis came into the being, and in 1950, Wright's, Ring, Mackie, Ferrari, and other designed the metal-on-metal total hip arthroplasty, but did not prove satisfactory because friction and metal wear. Most of the current day total hip replacement is been given by Sir John Chandler. In 1960, Sir Lee John Chandler has done pioneer work in all aspects of THR, including the concept of low friction torque arthroplasty, surgical alteration of hip biomechanics, lubrication, materials, design, clean air operating theater, etc. Between 1966 and 1988, Maurice Muller from Switzerland developed a plastic acetabular cup with a 32 mm diameter chromium cobalt molybdenum femoral head. In 1964, Peter Ring began using metal-to-metal components without cement. Concept of modular prosthesis developed during 1970, and cementless prosthesis came into the picture by mid-80s. Now come to the indication. The main indication for total hip replacement is pain, rather chronic pain. So the pain should be incapacitating and it should interfere with your day-to-day activity. THA is always an option for nearly all patients with disease of hip that cause chronic discomfort and significant functional impairment. In patients with limitation of movements, leg length inequality, and limb, but little or no pain, then they are not the candidates for total hip replacement. These are the indications: arthritis of hip in rheumatoid, juvenile rheumatoid arthritis, ankylosing spondylitis, and degenerative joint diseases like osteoarthritis, both in primary and secondary to slipped capital femoral epiphysis, congenital dislocation or dysplasia of hip, coxa plana, Paget's disease, traumatic dislocation, fracture acetabulum, and hemophilia. In cases of osteonecrosis, in cases of pyogenic arthritis and osteomyelitis, both suppurative and tubercular, in cases of congenital subluxation or dislocation, hip fusions and pseudoarthrosis, in failed reconstructions, bone tumors involving primary femur or acetabulum, or in hereditary disorders. Most common reason for total hip replacement is osteoarthritis, rheumatoid arthritis, fracture dislocations, and aseptic bone necrosis. Absolute contraindication for total hip arthroplasty is active infection in the joint, unless we are carrying out a revision as either an immediate exchange or interval procedure. Systemic infections or sepsis, neuropathic joint, and malignant tumors in which uh, inadequate fixation of component is not possible. There are some relative contraindications, and we should wait for the sometimes, like in acute or chronic local or systemic infections, in severe disease of muscles, nerve, blood vessels that could endanger life, periarticular bone stock deficiency, making it difficult or impossible for implantation, poor muscle or ligament tissue conditions, joint disease which may require alternative reconstruction, any disease that might result from operation and affect the function and success of implant, allergy to implants, particularly to metal like cobalt, chromium, nickel, etc., local bone tumor or bone cyst, pregnancy, and strenuous exercises like those persons who are involved in heavy labor, like heavy labors, athletics, marathon runners, etc. THR should be avoided. Now, why we should do the templating? Because templating facilitates the surgeon's goals of restoration of hip biomechanics in terms of limb length, offset, and center of rotation. You can match the opposite side if there is unilateral disease, and you can match the other side, contralateral side in THR if there was previous THR done already. And if there is marked discrepancy from templating on the table, that means the component is in malposition or malsizing, or there is some other problems like iatrogenic fracture has already happened. Prerequisite for templating is a good quality radiograph, and you need a template. It is in the form of transparency, and all the sizes are already printed on the templates. Nowadays, even the digital templates are also available. In the radiograph, magnification of the film should match the magnification mentioned on the template, which is most of the time it is 20% larger. Sometimes it is 10% larger. So you have to match that with the X-ray. A low AP pelvic radiogram with X-ray beam centered on the pubis is preferred for hip templating. The whole proximal third of femur should be visible and is located more or less in the same horizontal plane as the X-ray source. To evaluate functional length discrepancy, pelvic tilt in frontal and sagittal plane, AP pelvic radiograms should be taken in standing position with both iliac spine in the same distance from the film. Anatomical landmarks are first identified. This is the femoral shaft and this is the endosteal layer. Second is the greater trochanter. This is the saddle point. Lesser trochanter, acetabular roof, and the teardrop. Now I have to draw the mechanical landmarks. First is hip center of rotation. Then the longitudinal axis of femur, proximal femur. This is the distance, this is femoral offset, acetabular offset, hip length from a fixed point like from an interteardrop to a fixed point like lesser trochanter, and the limb length discrepancy is calculated. Hip center of rotation has to be difficult in cases of severe arthritis like this, but still in these cases, some part of acetabulum and femur is always preserved, mostly the lower part. In original rotation of center of rotation can be found at the center of circle fitted on the preserved part of femoral head. Generally, lower third of femur is preserved, And the preserved part of acetabulum, generally teardrop is always present and the medial wall. Femoral offset. The femoral offset is defined as the shortest distance between the femoral rotation center and the longitudinal axis of proximal femur. Now determine the acetabular offset. It is the shortest distance between the acetabular rotation center and the perpendicular to the interteardrop line. This is the interteardrop line, both side and the perpendicular on the inner side of interteardrop line. And the distance from this line to the hip center is the acetabular offset. Now calculate the limb length discrepancy. Like in this case, a line is drawn, inter teardrop line is drawn, and the distance from that line to the upper point of lesser trochanter is compared on both the side. And in this side, you can see there is shortening. Now the acetabular templating. Acetabular templating is done. The size of cup is matched according to the cup is placed. The medial side is just touching the ilioischial line. Inferior part of the cup should be at the level of teardrop, and the angle should be around 40 degrees. And this hip center is marked. Now femoral templating is done for a stain size, offset, neck resection level, and neck length. This is different for both cementless and cemented stain. In case of cementless stain, the inner industrial line should match the template, and this is the proposed cut level. So the adjust the template size until optimum contact between the lateral and medial industrial line cortex of the proximal femur is achieved. In cases of cemented stain, we adjust template size to allow for adequate cement mantle at least 2 to 3 mm on both sides for adequate fixation. In cases of coxa vara, usually the cut is lowered, neck cut is taken lower, and offset is increased. And in case of coxa valga, the cut is made at little higher level and offset is decreased a little bit. In cases of protrusio, the templating is done as per the principle. An attempt is made to restore hip center by medial bone grafting and lateralizing the cup to acetabular ring. Here also we template in the same way. The medial part is kept under ilioischial line and lower part of the cup should be at the level, and this part needs to be filled with the bone grafts. Now the applied biomechanics of total hip replacement. We have to discuss anatomical versus medialized cup, restoration of offset, normal versus high center of rotation. Medialization results in least stress of cuff head interface and adductor muscle with optimum outcome when femoral offset was increased to restore the global offset. The increased JRF seen with decreased medialization has been implicated in increased wear in hard-on-hard wearing and squeaking in ceramic on ceramic wearing. Downside of medialization include reduced range of motion, increased risk of bony impingement, risk of microseparation if global offset is not restored, resulting in accelerated wear. Loss of bone medially that may have implications for revision surgery. Also change in working length of muscle, and change proprioception due to non-anatomical positioning of the cup. Component containment is another important consideration when choosing depth of cup. Press-fit uncemented components rely on rim of peripheral cortical bone for their initial stability. Medialization past this support rim into cancellous bone can increase the risk of loosening. An over-lateralized cup is also at risk of loosening due to inadequate superolateral bone support. In contrast, a cemented component will require greater medialization for containment. Despite traditionally espoused benefits, medialization has deleterious effects too. Attention to acetabular offset and restoration of anatomical center of rotation has an advantage in terms of impingement, range of motion, global offset restoration, cortical rim press fit, and maintaining medial bone stock. We would recommend an individualized approach to each patient considering each of these factors rather than routine medialization for all cases. Restoration of global offset is must for longevity of implant and good functional outcome. If offset is decreased, there is increased load on abductors, leading to fatigue, pain, and limping. Also, there is high chances of dislocation. Increased offset leads to increased joint reaction forces and leads to early wear and failure. High hip center of rotation, that is sometimes considered in cases of DDH where center of rotation is tough to achieve. The high hip center technique is supposed to increase host bone coverage of socket without structural bone grafts, simplify surgical procedure, reduce anesthetic and surgical time, conserve adequate healthy bone stock for revision. However, it leads to insufficiency of acetabular muscle speculated to increase the hip load, lower the range of hip flexion and internal rotation, and accelerated wear. High hip center technique is acceptable while center of rotation located at the horizontal level with distance less than 35 mm from the inner teardrop line. Moreover, the medialization of this high hip center reconstruction is suggested. Cemented versus uncemented THR. Cemented THR use PMMA to function as a grout, bone cement as a grout, producing an interlocking fit between cancellous bone and prosthesis. Uncemented hip rely on biological fixation of bone to bone, a surface coating on the prosthesis. Which one is better is still a matter of debate, but cemented THR is gold standard in terms of survivorship. Uncemented is preferred in younger patients. Those have advantage of shorter surgical time and avoidance of cement-related complication. Cemented THR is preferred in older age group. Immediate full weight bearing in post-operative period is an advantage. These are the common components in uncemented hip replacement: the acetabulous shell, polyliner, femoral head, neck, and stem. Even in modular stems, the neck are also of different size. There are two types of cemented stems at present. One is collared, another is collarless. The concept of collared is that the stress transfer to femur is always desirable because it provides physiological stimulus for maintaining bone mass and preventing disuse osteoporosis. If prosthesis has a collar that is seated on the cut surface of neck, or if there is a layer of cement in the contact with the bone and under surface of collar, there will be axial loading of the bone. Although the role of a collar in preventing loosening of cemented femoral component has not clearly established, but it is the concept that any loading of proximal medial neck is likely to decrease bone resorption and thereby reducing stresses on proximal cement. Collar also serves as a simple mean of determining depth of insertion of femoral component, since vision is temporarily obscured by extrusion of cement. Now, the philosophy of this colorless polished taper steam. Bone cement is a viscoelastic material which under constant load deforms over time. They achieve stability through micromotion. These stems achieve stability through micromotion at processes cement interface, promoting slight subsidence of stem within the cement mantle. The generation of radial stress and ultimate compression at bone cement and processes cement interface. The CPT design helped to ensure that the processes remain firmly seated as cement deforms. The polished taper design optimizes the transfer of compressive force to cement rather than shear forces. Control subsidence in the first year is expected to occur, but after stabilization, subsidence is minimal. The polished surface allows the subsidence with minimal resistance or friction. The collarless feature allows subsidence and stabilization to occur without the physical constraint of a collar. Cemented cups are classically made up of polyethylene, cross-linked polyethylene. These cups have grooves to increase surface and to accommodate bone cement, and also picks to avoid bottoming out of cup in the acetabulum and ensure at least 2 mm uniform cement mantle all around. A wire ring is present for radiological assessment of cup orientation both intra-op and post-op. Newer generation cups are made of highly cross-linked polyethylene with different head options. When instability is anticipated pre-operatively, constrained cup or metal back dual mobility cup can be used. Uncemented THR. Uncemented hip rely on biological fixation of bone to surface coating of the prosthesis. Initial fixation is achieved by inserting a prosthesis slightly larger than the tapered bone bed, generating compression hoop stress and obtaining a so-called trace fit or scratch fit. Later on, the bone grows either into the rough surface or over the surface. That depends upon the design of the implant, and that gives ultimate stability to the implant. Now comes to the wearing surface. We have two options for femoral head, either metallic or ceramic, or we have three options for acetabulum currently: polyethylene liner, ceramic, or metal. Most commonly used is metal head on polyethylene or highly cross-linked polyethylene. Other options are ceramic on poly, ceramic on ceramic, and metal on metal. Metal and ceramic combination are not approved for using THR. This is the simple comparison of different articulating surface, the advantages and disadvantages. Most commonly used metal on poly articulation. It has good long-term result in elderly patients. New materials like highly cross-linked poly and antioxidant are available, but they don't have longer follow-up. Disadvantage is higher rate of linear wear. Now, metal on metal articulation was used earlier. Now they are banned. They had the advantage of reduction in wear, improve in range of movement, lower dislocation rate, and good initial results was there. They have the disadvantage of bone and soft tissue necrosis with zero tumor formation. Cobalt and chrome ions can affect the body. This was the main reason why these implants are not used nowadays. Relatively high rate of osteolysis and implant failure. Another option is ceramic on ceramic. They have extremely low wear rate, lower osteolysis, very high survival rate in terms of results, and harmless wear particle to human body. But the disadvantage is ceramic fracture, squeaking noise, and they are expensive. Another option is ceramic on poly. They have the advantage of ceramic and poly, and with the ceramic we use highly cross-linked poly now. They have lower wear rate. The only complication is alumina head fracture in this case. Implantation technique. The cup is implanted with an inclination of around 40 degree. The range could be 33 to 45 degrees. If inclination is less than 33 degree, it will cause impingement, and more than 45 degrees, there is chances of dislocation. Femoral anteversion is maintained as 10 to 20 degrees. Acetabular anteversion is maintained at 10 to 25 degrees, or the combined anteversion of 35 degree is tried. The range is 25 to 50 degree. Now the concept of combined anteversion came with the uncemented versions of implant. Unlike cemented stem where anteversion is controlled by the surgeon, cementless stem require a rigid metal design to conform to the rigid shape of the native proximal femur. This results in a wide variability of stem anteversion. There is thus the potential for cementless stem anteversion to be 10 to 15 degrees different than the anticipated 15 degrees of anteversion. If the stem has an outlier of 10 degrees and cup also has a 10-degree outlier of the anteversion, the combined anteversion could be 20 degree different from that expected. This possibility is the reason for considering the combined anteversion technique for combating positioning of technique for component positioning in THR, which prepare the stem femur first, so that the femoral stem anteversion is known before cup implantation. The cup is then anteverted according to stem anteversion to give a combined anteversion between 25 to 50 degree, lower for men and higher for females. The combined anteversion can be assessed over the table with this coplanar test. It's a clinical test. The test is the visual judgment of combined anteversion while the femoral neck and head are aligned coplanar to the acetabular mouth. The limb is extended, abducted, and internally rotated. This is basically defined for posterior approach. So the limb is abducted, extended, and internally rotated so as to get both these parallel, acetabular and femoral head. To keep both these parallel, and in this position, the degree of internal rotation to produce a coplanar head and cup is the combined anteversion, which we can assess on table. Thank you.
Okay, thank you, Ratnesh. Questions? I think we should get questions from the DNB students. Before they start, just one thing. You said the metal on metal were banned. I don't think all metal on metal prostheses are banned because the Birmingham hip is still being done. Okay, so I think the ASR is definitely banned, and there are a few others which have not been banned, but there are some of them which are still not banned. I think especially the Birmingham hip is not yet banned.
The DNBs?
Hello, sir. Good evening, sir.
Good evening.
One question is, sir, just suppose one patient come with the bilateral deformity already present, and then doing THR in that case, what is one should keep reference as a hip? If there is no
In limb length, etc.
Yes, sir. Templating, limb length, center of rotation.
Center of rotation can still be determined because some part of hip is always preserved, like lower part of femur and lower part of acetabulum, teardrop. But in that case, exact limb length discrepancy you cannot calculate. You can template and find the distance between the two center of rotation and adjust or do the THR on one side on clinical basis to check whether the stability and tissue tension everything, and other side can be planned accordingly.
Okay, sir. And sir, it is mentioned that in templating pelvis axis should be done in 15 degree of internal rotation.
Yeah,
Suppose
just
one 15 to 20 degrees. Suppose one patient come with there is no internal rotation possible.
so templating cannot be done in that case because you need a X-ray where the full profile of neck should be visible.
Yeah, but you can compare it with the opposite side if the opposite side can be internally rotated, okay? But
Okay.
if both hips are also sort of, you can't internally rotate, then you have to just, you do the for the acetabulum. So that's another problem with templating nowadays is that we get digital x-rays of different sizes, okay? All the templates that are designed with the old x-rays where you had a magnification of 1.1 or something like that. Okay, so
Yes.
those templates no longer work with the digital x-rays. So either you have to get x-rays with the correct magnification, or you have to use some form of computerized or digitized this thing,
Templating.
templating. Okay.
Yes, sir.
So if you
Amit
can,
has one question, sir. Amit, you can ask directly. Amit, sir, he want to ask leg length versus hip length and soft tissue balancing when considering lengthening or shortening. And these two questions, and one more is there that combination of femoral acetabular offset and stem insertion distance in varus versus valgus hip.
Varus and valgus is already defined. It depends. It actually you have to change the level of cuts in varus and valgus, and we usually try to compensate for the shortening in the joint only.
so
Where
hip
the shortening
length,
in
I
the
mean,
joint,
when you talk about hip length and leg length, I think he wants to know what do you mean?
we can maintain the hip length actually.
So you're just measuring the local height from the center of rotation to the lesser trochanter. Okay, so that is, and presumably if there is no other abnormality lower down, you will get the correct limb length as well. Okay, but if there's shortening lower down or below the knee, that's not going to be, you don't want to compensate that at the hip. Okay, you want to keep the hip mechanics correct.
If we try to maintain, if we try to lengthen it, then all sorts of problem will come. Like
Exactly, that's what I'm saying. So your
we
hip
have to,
mechanics
we
have
can
to,
manage this much of shortening,
yeah.
not more than that. And
So
if
you
there is
can,
supposed to increase the offset, then it will cause increased tissue tension, may be painful, and it will lead to accelerated wear.
No, you also, even more shortening at the hip, you may be able to deal with. But if there is a shortening more distally, you're not going to try to uh, get the limb length right by increasing the hip length. That's the hip mechanics have to be right. That's important. So you need to get the original offset and length, the vertical and horizontal offset. Some people talk about it as vertical and horizontal offset. You have to get that right, irrespective of whether there's shortening in the limb or not. Okay.
sir, you please switch off that share screen, sir.
Sir,
Ratnesh,
what is
stop sharing the
importance of
screen. Yeah, come on, Gautam.
sir, what is importance of acetabular offset, sir?
Acetabular offset is important just because not only acetabular offset, just if you are talking about the offset, there are two aspects. One is acetabular offset and another is global offset. You have to maintain the global offset anyhow. If you medialize the cup or you implant it is in a neutral, this original center of it. Acetabular offset is this point. This is the center of hip
Yes, sir.
from a perpendicular drawn on inter-teardrop line. This is the perpendicular drawn. So this distance is acetabular offset.
Yes, sir.
Initial concept was to medialize the cup. In that case, the acetabular offset was reduced, and they tried to increase this femoral offset.
So this was Chanley's concept of medialization. Okay. So Chanley, when he described his technique, his to try to medialize the acetabulum basically for two reasons, and then increase the offset of the femur and hope by that to reduce the wear as well as improve the abductum lever arm.
Yes, sir.
But having said that, there are other problems associated with that. So today you don't deliberately try to medialize the acetabulum. You try to get the correct center of rotation, both for the acetabulum and the femur. Okay?
Yes, sir.
So Chanley, go through Chanley's technique and his book. He talks about a
low friction arthroplasty.
Low friction arthroplasty. Yes, sir.
To actually medialize the acetabulum. Okay? Specifically aiming to medialize the acetabulum.
Yes, sir.
Sir, you please share
screen. Stop sharing your screen. Just if you go to the top, there'll be a red thing which will say stop share. Yeah, great.
And sir, a few questions I have, like, what is the status of the bilateral THR? Is it we can do it simultaneously?
We can do bilateral THR simultaneously, but you need first, that is not our problem. Most of the problem is associated from the anesthetic side or general condition of the patient. If the patient is
fit, I think, sorry, carry on.
Yeah, if the patient is fit and there is some reason for doing bilateral simultaneously, then we should go. Otherwise, we are just doubling the complications in THR in same setting.
So I think you need to look at the fitness of the patient, the morbidity of the surgery, and the anesthetic risks. Okay. So I think in a young patient with sort of fixed hips where you think he's not going to be able to fix, especially deformed hips, where you think if you do one side only, he's not going to be able to still walk, then you consider doing them together. But I think there is a very few indications where you have to do bilateral hips together. Okay. I think it's safer for most patients in terms, because it's difficult to do it, although you can do anterior approach or posterior approach if you do it in the prone position together with the same prep, but usually it means you are doing the posterior approach in the lateral position. So it means prepping and draping twice. So twice the amount of time. Blood loss increases, reaming increases. So all those things you need to look at and then decide whether it is really worthwhile doing it in one go or safer to do it in two. And recently, especially even with knees, which were being done bilateral by a lot of people most of the time, there have been a couple of cases which have created issues for people doing bilateral knees. So yes, there's still no reason why, if all the you follow the guidelines, make sure the patient is fit, the anesthetist is fit, do one side, make sure everything is okay before starting on the second, and document all that, you're probably still okay. But if you then have a complication, it has ended up in some issues in a couple of cases somewhere.
And sir, if you are doing it in 2 stage, so what is the ideal interval in between, sir? Is it?
Minimum is 6 weeks is recommended as per. as per.
It again depends. Now you can do it in the same admission, but then ideal would be wait for 6 to 3 months so that the patient's sort of physiological parameters come back to normal. Okay, every surgery has some effect on the body. Yeah. So depending on how bad. So again, if you want to do it in the same admission, if they are very badly deformed hips, maybe some advantage in them doing them together so that you can mobilize the patient.
What is the role of tranexamic acid, sir? Because a few of the surgeons use it before the systemic or sometimes in the knee joint locally.
So are you asking that question or you?
Yes, sir. No, sir. I
the answer of that question.
No, sir. I want to know.
So you know the answer. Why don't you tell them?
No, sir. But for local and systemic, the difference that I want to know, sir. Because sometimes they use it locally also in knee joint. I have not seen in the hip, but few of the surgeons, they are doing it locally in the knee.
Yeah, because in the hip, it will not remain contained in the hip. No?
In some of the combinations cocktails, they are using the tranexamic acid for local infiltration around the joint.
Yeah, so for the knee, that's very common to use tranexamic acid. It's basically to reduce bleeding, and there's some evidence to show that it does reduce bleeding. You have to be careful. I mean, there is no sort of study which suggests that it increases the risk of DVT, but that's a worry with some of the older patients where some people say that if you increase the clotting, maybe you will also increase the risk of DVT, but there's no evidence so far of that. But there is clear evidence in some studies to show that it does reduce the amount of bleeding post-op, okay? Especially in total knees. And in fact, a lot of major surgeries, people are using it nowadays.
Okay, sir. Sumit want to know recent advances in cup and stem designs.
That will be discussed in a different lecture. It's not like a discussion. I'll cover it in probably next class.
Okay, sir. Sir, you have mentioned regarding squawking. What is that, sir? In ceramic on ceramic, you have mentioned.
Squeaking, not squawking.
Especially when there is
squeak.
Okay, sir.
That's a sound you get when you're moving the hip, okay? Because of the two surfaces. So it's a troublesome thing. Whether it is significant in terms of the prosthetic sort of life, etc., we still don't know. But people say there's usually some mechanical reason for it to happen, okay? So nowadays, with the newer ceramics, the incidence is much lower than with earlier. Similarly, breakage is much lower than it used to be earlier. So one of the worries used to be with ceramic is of breakage of the prosthesis head or even the liner. Okay, but that with the newer ceramics is very rare.
And sir, yeah.
So two more questions. Effect of lumbar lordosis on version, sir, of a tabular cup, and when performing THR in the cases of the spinopelvic imbalance patient, for what is the first to do, spinal realignment after THR or first THR then spinal realignment?
I think second question first. Spine should be done first.
Okay, sir.
And then THR should be planned, because the orientation of cup will depend upon the movement of the spine, whether it is fixed, because the movement changes when you sit, movement change, axis change when you sit, when axis change when you stand on your leg. So the angles change. The cup position is also changed. That I will cover in next lecture.
Okay, sir.
Again, so it depends. So if you have a fixed deformity like in ankylosing spondylosis, this is one of the areas where you get all these maximum problems with either with pelvic sort of either they are tilted anteriorly or posteriorly depending on the deformity. Okay, so I think you can't do much about the spine in those. Okay, so you have to then plan your anteversion based on your acetabular tal. So the transverse acetabular ligament becomes your guideline to anteversion, etc. Okay. And you may have to actually balance it with the position of the femoral stem. Okay, so sometimes in those it's useful, like getting your femur prepared also and checking at what position it's most stable. Okay, so it's not always very easy. So you need to judge all that. It depends on whether the deformity is only due to the spine or the hip deformity as well. So there are a lot of things you need to look at in those situations. Okay, again, spine will depend on how much the spinal problem is. Now, if it is major, then definitely you need to deal with that, because otherwise, if there's a huge tilt because of the spine, your positioning of your hip becomes very difficult. Okay, so if it can be corrected, then it makes sense to correct that first.
Okay, sir.
In ankylosing spondylosis, it's just a stiff spine in flexion or extension, and it's very difficult to deal with that. And you would then have to anteversion based on the position of the acetabulum and the transverse acetabular ligament. Okay, so you have some of these ankh spondylosis. When you do a AP pelvis, you get either an inlet or an outlet view.
Yes, sir.
Okay, so that will give you an idea that there's a huge tilt in it. Okay.
Okay, sir.
And sir, regarding the press fit implant, sir, what is the relation of size of femur and implant? Because sometimes I usually have confusion during the OT. Sometimes it is one size less or two sizes.
It is actually one size means 2 mm. Usually we keep framing 2 mm less than the size of the cup, and then we press fit it. Right? It fixes with the elasticity of the bone. Bone one expands and then it holds the cup. And second concept is the scratch fit. The surface is very rough and there is some scratch between the two. So both press fit and scratch fit work. So 2 mm is the size. Sometimes 1 mm is also, but 2 mm is generally preferred.
Yeah, so usually for most uncemented hips, you ream 2 millimeters less than the size of the cup, but you need to check with the trial. Sometimes it can get difficult. So in very sclerotic bone, you may have to go 1 millimeter from the size of the acetabulum. Okay. So you try to put it in with 2 millimeters and you are struggling to put it in.
Sir, good evening.
Yeah.
Sir, I want to know about, sir, calcar pivot and medial stem pivot. The, sir, loosening of stem, aseptic loosening of stem, sir. How medial stem pivot occur, and what is calcar pivot?
I have no idea.
Actually, sir, I studied, but I didn't understand.
Wait for the next class, next and subsequent classes. First for the complications.
Sir, and sir, one more question is there.
Yeah.
So basically that is based on where the prosthesis is pivoting. Okay.
Yes, sir.
You understand? So when it's loose, there's a movement in the hip, in the prosthesis. So if that is centered on the rotation is at the calcar, it will be a calcar pivot. Okay, I don't think it's.
Sir, in the book, it is written that in the medial, superomedial, if there is less cement on superomedial side and inferomedial side, then there is a medial stem pivot.
Yeah.
But I don't understand, sir, how there will be less cement and how it will loosen.
That is osteolysis in superior medial direction.
So when you put in your stem, it doesn't mean there's equal cement all around. Okay, it depends on the position of your stem. So when you put it in varus,
yes, sir,
you will have less cement laterally than you have medially, and vice versa. Okay,
yes,
you understand? So just because you put cement doesn't mean there's equal cement. If your stem is centered, you'll have equal cement all around. But if you're in varus or valgus, then you'll have more cement on one side than the other. Okay.
Sir, and one more question, sir. How do we, sir, approach towards a patient with aseptic loosening due to osteolysis? How do we treat, sir? Conservative or surgical?
So once it's loose, there's, how do you treat conservatively? Okay, because it's going to progress.
Yes.
So first you have to, so not every osteolytic lesion is a significant loosening. Okay. So first you have to decide whether there's loosening in terms of symptoms. So what symptoms do you get in loosening?
Pain.
Pain, sir, most significant.
So when?
Startup pain, sir.
Sir, pain during walking and weight bearing.
So the classical symptom of loosening is that when they sit for some time and they get up to walk, that's the time when they have maximum pain. Okay. And then again, after some time when they walk a bit, it settles down. And then after some time, they again start having pain. So that's classical of loosening. Okay. Okay. So that then you need to rule out infection. Okay. You can't say it's aseptic loosening till you've ruled out infection. Okay. So then you have to do the necessary investigations, the blood tests, scans, whatever you need to rule out infection. Okay. So only, and then once you decide it's loose, then really you need to revise. There's no, unless it's an elderly patient who is not fit for surgery and you just want to sort of protect them. So then you protected weight bearing, maybe ask them to use a frame and wait and hope that nothing happens. Otherwise, the losing will progress and eventually end up with a periprosthetic fracture. Okay. So once you decide it's loose, there's no question of conservative treatment unless the patient is unfit for surgery or the conditions are such that you want to avoid surgery for whatever reason.
Sir, one more question is there. Sir, what is the significance of transverse acetabular ligament while placing the cup?
That's what we just talked about. Okay. So that's your best guide to the anteversion, okay, of the cup. Huh?
Yes.
So there are things like keep the patient so on the based on the patient's positioning. That means if it's horizontal or lateral, you do your anteversion based on that with the guides. But even that is not always reliable. So they found that if you use the transverse acetabular ligament and contain the hip in that position, okay, you understand? Then that is in a way a very good guide for your anteversion and even your inclination.
Also.
Okay.
Yes.
We have to keep the lower end of cup also inside
that area. So if you keep it just at the margin of the transverse acetabular ligament and position the hip according to that, the chances are you will be in the right position. Of course, in very deformed cases, you need to look at other parameters also. If it's already sort of there's either too many osteophytes, then you need to find out the transverse acetabular ligament. Almost, I think they say 97 to 98% cases, you can usually find it. Okay.
Even in cases of revision, they are helpful.
Yeah.
Because there is massive loss.
So if there's significant protrusio, then you need to then get the acetabulum in the right place. It's not going to be useful till you get the acetabular centered right. Okay. You can't go right in. So that's also a guide to that you're getting your acetabulum centered correctly as well.
Sir, one question from history, sir. Sir, John Charnley has started advocating regarding transtrochanteric approach for total hip replacement. Do you have any specific indication currently, sir, for total hip replacement in which you should go through that approach?
Couple of things where it's useful. I won't say it's one is if patients have already had a sort of something like a McMurray's. Okay. Especially using this Wainwright spline where you put it into the thing, there it's very useful. I think sometimes in really osteoporotic bone with a lot of overriding, you reduce the risk of fracturing. Okay. Some other, say if you have a coxa vara with a trochanteric overgrowth and you want to bring down the trochanter, there it's useful. Okay. But so there are certain indications where it helps. Okay. Previous fractures where the trochanter is off, again, you may have to get it to the correct position. So doing an osteotomy makes it easier. And today, some people are actually using the trochanteric flip osteotomy as an approach. Okay. Not the traditional osteotomy, but the trochanteric flip as an approach to the hip. Okay. We haven't done that much, but that's some of the people are using that as an approach to the hip.
In that case, sir, trochanter, how trochanter fix, sir? Trochanter flip?
So
Last class we have discussed.
no. Advantage of the trochanteric flip is that the thing falls back into position. So you don't need a lot of fixation. A couple of screws is all you need. And the prosthesis will usually give you room to get a couple of screws through. Okay. Understand? The prosthesis in the trochanteric region, there's always some room on either side of the prosthesis, anterior and posterior. Okay.
Okay.
You should be able to get the screws in. Yeah. And unlike a traditional trochanteric osteotomy where the trochanter floats away, here it tends to fall back into position. I haven't used it personally myself for it, so but this is something which I've heard from a couple of people I've talked to in meetings that they're using that.
They sometimes say the trochanteric flip is better than attaching abductors.
Exactly.
Soft tissue attachment of the adductors after surgery. So some of them actually taking this with some bone layers also.
And so, does the short stem type as of hip prosthesis have any advantage over standard stems? How to decide between short stem and standard stem when to use?
So short stem came into vogue for some time, the proxima hip, etc., where people would use these very small stems.
Yes, sir, I have seen in X-ray only.
They've fallen out of favor and now people don't seem to use it. So you might use it in some very major anatomical problems where you find it difficult to go beyond a certain point. Okay, but so it was being advocated as the best hip for some time to use shorter stems, but now they found that the complication rates are high, so they don't use it as a standard. Now, so similarly, so in some anatomical sort of deformities, etc., people are using computer CAD design. So you do a 3D CT, then design your prosthesis according to that. Okay, so there you can use it, but by and large, as a standard way, it's no longer used here. Or most people have stopped using it. There may be some people still using it.
With the theoretical advantage of proximal loading of neck, more physiological loading, that was the theoretical advantage. But in vivo,
practice
that didn't work. Actually.
Yeah.
Actually, that didn't work as per the theory.
One Italian guy had come to Delhi to Max and demonstrated it some years ago, I mean more than 10, 12 years ago. And it was the new thing in town kind of thing. But it didn't last very long.
Sir, some advantage and disadvantage of alloprosthesis, sir.
Are we talking about alloprosthesis in a basic THR?
No, sir. Actually, asked in exam, sir.
So that you can
in subsequent classes, don't worry.
Yeah.
Okay.
Or you can ask
all the topics, even aseptic loosening, periprosthetic fracture, bone defect management, everything will be covered in subsequent lectures.
Okay.
Just one question regarding that interposition arthroplasty, sir. It has gained success in all non-load bearing joints, but not in load bearing. Is any future of that, sir? Interpositional arthroplasty, because that is history only. We are not seeing.
So I know history is important, but doesn't mean you repeat the mistakes. Huh? So you have options. It was done at a time when there was no option. You didn't have good total hips available. And if you wanted a mobile joint, you avoided a fusion. Okay, but now for the hip joint or the knee joint, there's no real role for an interpositional arthroplasty because you're going to get an unstable position hip. Huh? Okay, so if you have to do something like that, there is a pelvic support osteotomy which gives you some support, but the interposition doesn't really have much role here. Okay.
So I think most of the question is covered. Just one question regarding that metal on metal, what you have discussed, sir. Do you think any future of metal on metal bearing total hip arthroplasty, sir? Because that is one controversial question usually asked in the exam.
Yeah. Okay. So what is the reason it's not been it's fallen out of favor?
Because of bearing, and that is quacking properties.
Wear is actually not bad, but what you get is the debris. Whatever where you get, the metal ions get into the circulation. Okay. And that causes, now they found nickel toxicity, chromium and cobalt eventually may cause even cancer of the liver, etc., or hematological problems. Yeah. The second thing is the alveol, okay, which is this massive osteolysis that you get with some of them lesions. Okay. So then it's a big problem because then you have to deal with it because it leads to loosening. Okay. Now, if your metallurgy improves to a situation where there is zero wear, okay, then maybe it will be something that people would think about doing again, but we haven't reached that yet. So metal on metal hips came back into the reckoning because of some of the earlier Mackey-Farrar hips and similar Peter Rings hips continued, especially Mackey-Farrar. The ones that got bad went bad very early, but the ones which stayed and had no problem, some of them were still going on for 40, 50 years. Okay, so people then wondered whether, and at the same time, you had problems with wear with the standard hips, and then it was the poly wear that was the problem. So people then started thinking to go back to metal on metal hips, and initially we had great results. You had the resurfacing with metal on metal initially with a lot of enthusiasm, and that hip, a Birmingham hip, which is a surface replacement, is still being used. Okay. So if you know, recently Andy Murray, the tennis player,
that's in sports person,
he had it and he's now back to playing competitive tennis. Okay, so he's playing in tournaments. At present, he won his match against somebody recently in a tournament in New York. Okay. So the problem was the fact that you got all these reactions, etc. Somehow the Birmingham hip has less of this, probably because of the metallurgy, we're not sure. Okay. But certainly some of the hips, especially the Metasol and few others, ASR, etc., did have problems.
Sir, just one question regarding longevity, that ceramics on poly or ceramics on ceramics, which one is better, sir, in terms of longevity? This is also a little controversial, sir, because most of the people.
So in terms of where ceramic on ceramic is supposed to be the least, okay? Full stop, okay? But ceramic on highly cross-linked poly is very close, okay? And you don't have the problem of squeak. So probably that's the preferred option for most people. But ceramic on ceramic in real terms, if you don't have the squeak, is the one that's going to last you the longest time.
Sir, in one recent literature, I have seen that vitamin E is also there in poly. They are putting vitamin E to increase
That's
durability.
not recent literature, it's pretty old literature. Huh?
So,
Okay.
I have read it in 2018.
Okay.
I think. Yeah.
You know, I think no, it's been there for close to 10, 12 years, I think.
They all have theoretical advantage, but clinical results is still means long term.
I think vitamin E they are using and this thing, but it's not new. It came almost 10, 12 years ago. If you read that article which you got
Yeah.
the reference of, and then see where it started, it will say it. If you look at the references on that article, you'll find that it's not that.
Results are probably not very encouraging because companies are now not very much interested in those polys.
Because the highly cross-linked is obviously doing better.
Highly cross-linked is definitely better. It has wear characteristic very similar to, not similar, but exactly very means comparable to ceramic on ceramic. But still, in very young patients, ceramic on ceramic is still the best option.
So, sir, I think it's
Yeah,
for
I think
basics.
we should call it a day.
It's very nice, sir.
Past 6:30. Yeah. Okay. Thanks.
Thank
Thank
you,
you, everybody. I think we should call it a day, and until next week, we'll decide what we are doing next week, and then let you know. Okay.
Thank you so much, sir.
Okay,
Thank
bye.
you.
Right?
Thank you, sir.
Thank you, sir.
Bye bye. Other topics will be discussed later on. Bye. Good evening.
Thank you, sir.
Thank you.